First, to apologize for speaking before Tyrone, but the reason is that I have to take a plane this night, and Jan was thinking it was probably too risky to have a plane at 7 and depart from here at 5. So, so we decided to switch. So I will talk about the durability before you know anything about the techniques, but I think I will try to make it clear for you. So Gebrin has already shown you that. These are the different techniques that we have been using in our institution to cure or to take care of patients with aortic regurgitation. Some of them we've learned that they were not long-lasting, and Gebrin changed his mind and changed the technique, and I will show you some examples. If you look at the long-term survival of that operation, you see that at 10 years, an excellent result, since we more than 90% survival rate. If you look at the freedom from more than 2 aortic regurgitation, we are about 80% of the patients. So you would say, well, at 10 years, there's probably 20% with recurrent AI, but as I indicated, most of them are moderate AIs, and they do not have the same behavior as the 80-year-old TAVI patients, and just the demonstration of that is that despite some patients having recurrent AI, they have an excellent survival, which is exactly the same as the one from the age and gender matched Belgian population. Now, we've learned that not all the valves are repairable, and I think this is something which is very important. You've heard about the classification. Type 1, normal leaflet motion, essentially dilatation of the ascending aorta, or at least the root. Type 2, prolapses, and type 3, these are the valves with very poor quality tissue, and as you can see, those have a significant recurrence rate after a couple of years. So we've learned that maybe these valves are not repairable and we do not tackle them anymore. These are indications for replacing these valves. So the first thing is to be able to decide ahead of time whether or not the valve will be repairable. So that's the job of the cardiologist and the echocardiographer together with the surgeon. And that's the study we published 5 years ago, in which we looked at the valves before the operation and decide, as cardiologists, whether or not the valve would be repairable, and looked at what the surgeons did in the operating theater. And as you can see, when we said that the valve was repairable, most of the time the surgeons did repair the valve. There's only 3 replacements over 100 patients when we deemed the valve to be repairable. But we were surprised to see that once we thought the valve should have been replaced, the surgeons nonetheless tried to repair about a third of them. And about the 17 patients that were repaired despite our assessment that, and the surgeons didn't know anything about that assessment, that the valve should probably be replaced, half of them came back with recurrent aortic regurgitation and needing a reoperation. So clearly, we are able to identify the different types of aortic regurgitation ahead of time. And since we now know that type 1 and type 2s are highly repairable, we probably now concentrate only on those patients. This is showing you the repair rate in the different types. So about 90% more of the patients with type 1 or type 2 got a repair, and about 50% of the type 3s got an attempt to repair, and you see that the event rate in the next 4 years is much higher and significantly higher in the patients who got an attempted repair in type 3 dysfunctions. And this is shown as a Kaplanmeier curve. So the first thing, I think, in assessing the potential for durability is to be able to tell whether or not the valve is repairable based on the experience that we have in this type of pathology. And then there's also the experience of other groups, and this is the experience of the group of Hamburg, Jochen Schaffers, and clearly the freedom from reoperation in his earlier experience, and he uses some different techniques than uses Gebrin, shows that there is a considerable difference between the freedom from reoperation of patients operated for tricuspid aortic regurgitation compared to bicuspid aortic regurgitation. And I think this is quite interesting to see the reasons why these bicuspid valves do fail, because if you understand that and you try to correct that, then maybe at one point in time you will be able to avoid a recurrent AI in those patients. The first thing that they learned, and that we've learned too, is that if it's necessary for you to take out a lot of tissue because of diseased tissue, calcifications, etc., and you have to patch these valves with pericardium, this will not be sustained over time. So obviously, it's better to tackle bicuspid valves where you know ahead of time that you will not have to patch. Essentially, this is the quality of tissue. So the real type 3 bicuspid valves are not good indications, because of course you can repair them. You will maybe get a good result at the end of the operation, but at the expense of a very important reoperation rate. Something which is very peculiar, if you try to preserve the bicuspid morphology, which very often is asymmetrical by doing your repair, it's leading to a high rate of recurrence. If you tackle valves that are already symmetrical, or you try to make them symmetrical, it seems that you get much better results. And I don't know why, but since the beginning, Gebrin has been symmetricalizing these valves all the time. So instead of getting this 120 degrees configuration of the classical bicuspid valve, he was always trying to make them 180 degrees. And this is maybe the reason why we got so good results with bicuspid valve repair. Things that we have also learned and that we didn't know initially, and now we're starting to understand the importance of the aortoventricular junction. We all knew of the importance of the sinotubular junction, but very few of us did know that the aortic ventricular junction was also very important. And indeed, those that have very large annuli do fail more frequently than those that have smaller annuli. And this is true for the pre-op dimensions as well as for the post-op dimensions. And indeed, Gebrin alluded to that. If we compared similar patients in whom we did a reimplantation technique in which we stabilized the aortoventricular junction compared to the others in which we either did nothing or did only subcommissural annuloplasty stitches, you see that the recurrence rate is much larger if you do not stabilize the VA junction. So stabilizing the VA junction and reducing the size of the of the aortic annulus is of tremendous importance, and this is probably the reason why we do not have a major difference between bicuspid and tricuspid valve in our experience at variance with what happens in Hamburg. So this is something that I wanted to say, is that preoperatively we already know a lot of things about the risk of recurrent AI, and probably those that in which we can adapt the surgical strategy to take care of this. It's okay, but if you have a type 3 dysfunction, you probably better replace the valve. So first thing, type 3 dysfunctions are probably not amenable to valve repair, or at least most of them are not. So now if you attempt a repair, at the end of the operation, are you able to tell which patient will have recurrent AI and need a second pump run? Maybe you will not be able to repair the valve and you will have to replace it at that time, but at least you would have identified factors that will prone the patients to recurrent AI. And we did this analysis in a large number of patients, about 200 consecutive patients that underwent repair. We made a lot of, a fellow did a lot of measurements, both pre-op and post-op on the valves, and make you see here everything that was measured. And there were quite a few recurrences, and this is with the early part of our experience, and that was something very important because we learned a lot from this. And you see that persistent of cusp prolapses was seen in a large number of patients, restrictive cusp motion in some of them. There was some dehiscence of valvular suture, and then of course there were patients that in the follow-up had aortic dissection or endocarditis. This is a completely different mechanism. And if you look at the patients with no AI, mild to moderate AR, or severe AR in the follow-up, you see that already the fact that we had tackled a lot of type 3 dysfunctions at that time was responsible for a large number of these recurrences. So obviously, these were the wrong patients to operate. We didn't know at that time. We thought that, you know, if you patch with pericardium, this would be very long-lasting. In fact, it was not. And then we looked at the characteristics of the valve immediately after repair, and we saw that there were a lot of differences between those with recurrent AI and those without recurrent AI. And the first of these differences is the length of coaptation that was achieved at the end of the operation. It was very small in patients with recurrent aortic regurgitation. The second parameter that was very important was the location of the tip of coaptation. We didn't realize that by some maneuvers we were pulling down the leaflets down to the annulus and sometimes below the annulus with a very low coaptation. And of course, this cannot be long-lasting, because if you have only 1 millimeter of coaptation and this coaptation occurs in the LVOT, the tension on the leaflet is going to be tremendous and it's going to fail. We didn't know that before. We should probably have, but this was something that clearly was identified as a mechanism. And one thing that we did not understand at that time, but we understand now, is that if you still have a very large annulus at the end of the operation, this is probably not good. And by multivariate analysis, there were a series of factors that came out to be independently associated with the risk of recurrent AI: the coaptation length, the location of the tip of coaptation compared to the annulus size, and the presence of residual AI. And here is an example. Maybe it will not be showing up very well. This is a Marfan patient with a severe aortic regurgitation pre-op. Then there is this reimplantation technique and valve sparing operation done. And as you can see, there is already some degree of prolapse of the anterior cusp. And now you can clearly see here that the prolapse of the anterior cusp 1 year later is significant with significant aortic regurgitation. So we came up with an algorithm that takes into account the different parameters that were found in the multivariate analysis. And we applied that algorithm, at least our anesthesiologists do in daily clinical practice. The first thing they look at the end of the operation is whether the tip of coaptation is below the annulus. It should be in the middle of the sinuses, but if it's 1/3, 2/3, it can still be considered acceptable. What is not acceptable is that the tip would be below the annulus. You see that if it is the case, whatever the amount of regurgitation, some of them have zip of regurgitation, the risk of recurrence is 71%, and redo rate is about 1 patient out of 2. If the coaptation occurs above the annulus, then we look at the presence of any degree of residual AR. And if there is no residual AR, the recurrence rate is 2% and the redo rate is 1%. So coaptation above the annulus without regurgitation, excellent results. Large number of patients, you see, that's 81 patients. Now, if you have some degree of residual AI, if it's moderate, it's of course unacceptable, but it can be mild and sometimes trivial, and these are included here. Then we look at the length of coaptation, and this was done by ROC curve analysis, and it turned out to be 4 millimeters. So if you have your coaptation above the annulus with some degree of AI, if you have a long coaptation, recurrence rate is low, 2%, redo rate 1%, versus less than 4 millimeter, where you have something like 1 patient out of 5 that will be coming back. So that means that at the end of the operation, you can predict how many patients will need the reoperations. Certainly, if the coaptation is below the annulus, you need to do something. You cannot leave the patient like that. He will come back anyway. If it's above, look at residual AR. If there is, look at coaptation length. And these are the curves that Peter showed. So the first 2 groups, you see that you have almost no event after 4 years. That was 7 years ago. We should probably do that study again with 5 years of follow-up more, but at least at 4 years, there was no event in the first 2 groups. So these are the patients with excellent results. They can go back home, not immediately from the OR though. And these are the patients where the surgeons need to do something else during surgery. Of course, at that time, we didn't do it. But today, we go back on pump, and either we refix the valve, and in some cases, we do a replacement. So this is my last slide. This is real life. Some patients left the operating room with that. it will never occur again. That was the early experience, and when we look at this example, the anesthesiologist froze the image when the valve was closed and measured a pseudo-coaptation, because there's clearly no coaptation there. This is a relatively good result, a coaptation which is long and occurring in the middle of the left ventricle, no AI, and a coaptation length more than 4 millimeters. So I hope that I convinced you that not only you can predict ahead of time which are the valves which are repairable, and these are principally the type 1 and type 2s. Some of type 3s can be repaired with caution. And then at the end of the operation, you have tools to predict which one will be coming back, and then you can plan either a new approach for the repair or to replace the valve at the time of the initial operation. Thank you very much for your attention.